In retrospect, this patient may have been a candidate for watch and wait rather than immediate surgery. And selected patients with a complete or near complete response can achieve organ preservation with regular endoscopic and MRI surveillance. Multidisciplinary assessment is important to identify suitable patients for watch and wait, and underlying biology is the key determinant for the overall outcome. So I'm going to also do a case presentation. And it's our session is on response adaptive management in GI oncology. So I'll use a case of a locally advanced rectal cancer case to discuss our opportunities for watch and wait. So organ preservation was first identified by Angelina Habr-Gama in 2004 with a seminal paper. And she presented this paper where over 265 patients with distal rectal cancer were treated with locally advanced with neoadjuvant therapy. And she demonstrated that the 5-year overall survival for patients who were given non-operative management was better than patients who had surgery and ended up having a pathological complete response. But of course, the field of neoadjuvant therapy has moved on since then, and we also have TNT now. And this seminal paper by Julio Garcia-Aguilar from MSKCC, the OPRA trial, they demonstrated that preoperative TNT followed by selective watch and wait approach does not compromise disease-free survival compared to historical controls who receive standard care treatment. And they also demonstrated in this trial that CRT followed by consolidation chemotherapy was associated with a higher rate of organ preservation compared to induction chemotherapy, achieving a very impressive 3-year TME-free survival rate of 53%. And this is the MSKCC 3-tier schema for the grading for tumor response. On the left-hand side, we have a clinical complete response, where we see endoscopically there is a flat white scar, telangiectasia, and no ulceration or nodularity. In the middle segment, we have an example of near complete response, where there are some minor irregularities or superficial ulceration, small tiny nodules. And many centers now will offer watch and wait for patients with clinical complete response and also near complete response, because a proportion of these patients with near complete response will eventually, with time, end up having a complete clinical response. And on the right-hand side, we have patients with incomplete response, where there's clearly visible tumor, and these patients are offered surgery. So I would like to present patient SK. He's a 68-year-old male who has a past medical history of hypertension and initially presented with a positive FOB. He had a colonoscopy in March 2024, which demonstrated a near circumferential rectal cancer at about 11 centimeters from the anal verge. He was actually offered upfront robotic, tumor-specific mesorectal excision and a loop ileostomy. And the pathology at that point demonstrated moderate differentiated adenocarcinoma, PT3N0, extensive vascular permeation, and all margins were clear. He then completed a course of adjuvant Xeloda. But then he presented to clinic 11 months later with new onset tenesmus, and on digital rectal examination, he was found to have a 1 centimeter mass near the anastomosis with bloodstained mucus. His CEA at that point was 3.5. He proceeded to have a sigmoidoscopy, and this identified a 1 centimeter mass noted just distal to the anastomosis at 6 o'clock, and the biopsy is confirmed adenocarcinoma. And you can see also here that the anastomosis was upstream about 5 centimeters from the anal verge. And this was a surveillance MRI, which demonstrated that the tumor was indeed distal to the anastomosis and was breaching the intersphincteric plane. He was discussed at a tumor board meeting, and it was recommended that he should have chemoradiotherapy followed by APR. The patient, however, was very reluctant to have surgery because it would result in a permanent stoma, but he ended up having chemoradiotherapy, which was completed in the middle of October last year. And this is the post-chemoradiotherapy sigmoidoscopy, and it shows a endoscopically a complete clinical response. Digital rectal examination showed a smooth and patent anastomosis, and also a smooth scar was felt at 6 o'clock just on top of the sphincter. And endoscopically, there was a flat white scar with telangiectasia, no ulceration and no nodularity. And indeed, a full colonoscopy was done, and it showed no other mucosal lesions seen. And this is his post-chemoradiotherapy MRI. And here you can see that there's the previously seen recurrent tumor is no longer visible, and there were no suspicious pelvic lymph nodes. So actually, the patient underwent a robotic APR, closure of ileostomy, and a formation of end of colostomy. And the pathology came back as being PCR, no residual tumor, 0 out of 7 lymph nodes were involved. He was discharged on post-operative day 22. It was complicated by small bowel obstruction requiring a TPN and minor perineal wound delayed healing. So in retrospect, this patient may have been a candidate for watch and wait rather than immediate surgery. And selected patients with a complete or near complete response can achieve organ preservation with regular endoscopic and MRI surveillance. Multidisciplinary assessment is important to identify suitable patients for watch and wait, and underlying biology is the key determinant for the overall outcome. Thank you.